Doctors, we are live.
Okay, good morning, friends. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the Tamil Nadu Ophthalmic Association, I have great pleasure in welcoming you all for this very important webinar today, which is the Crusade Against Diabetic Eye Disease. On this very important day, the World Diabetes Day. As you know, Tamil Nadu Ophthalmic Association has become very vibrant, and the theme for this year is Tamil Nadu Smiling and Tnoa Shining, and we are just doing that. We are having webinars almost every week, every 5 days, and every first month, every first Friday of every month, we are having the Walk the Talk series with the luminaries of Tnoa. We have done already 2 of them, and then we are also doing what is called the Tnoa ARC PG Catalyst program with various it's called the master class program with various masters. Couple of days back we had on cornea by Dr. S.K. Rao, and then again on the 3rd or the 4th Sunday we are having the Tnoa Connect series, wherein we are connecting all the major institutes across Tamil Nadu. As you know, all the major institutes of ophthalmic teaching in India are in Tamil Nadu, and Tamil Nadu is the mecca of ophthalmic teaching, I would say. And major institutes are there, and we thought we'll connect everybody. And this is called the Tnoa Connect series on every specialty of ophthalmology. A couple of weeks back, last month, we had, along with Shankar Netralia, on pediatric ophthalmology update. This is a initiative which is taken by the Tnoa to spread the knowledge to everybody, not only the residents, but also the practicing ophthalmologists, the general ophthalmologists. And today, it is a combination of both the general ophthalmologists, the specialists, as well as the diabetologists and the physicians, everybody coming together. And this is a crusade against diabetic eye disease. And we all know that diabetes is a very major problem. And because of that, the diabetic retinopathy is also a very major problem in this country. And to elaborate or discuss on these issues, we've got some fantastic speakers, fantastic panelists. I have the greatest pleasure of introducing the panelists first, and subsequently Dr. Ravi Shankar, my co-moderator, will introduce the speakers as they come in. So Professor Shanta Ram is, as you know, is I would say the colossus of diabetes in this part of the world. He is a professor of ophthalmology, professor of diabetology, and now former vice chancellor of Tamil Nadu MGR Medical University. In my opinion, he is a person who is the father of all the diabetologists. He is a very knowledgeable person. He is academically very, very strong. And in my opinion, the gold standard of diabetology as far as Tamil Nadu or this part of the country is concerned. We're very happy to have Dr. Shantaram will be joining us maybe by about 11:20, 11:25. Then we have Dr. Sriram Gopal. Dr. Sriram Gopal, as you know, is one of the office bearers of Tamil Nadu Ophthalmic Association. He is joint secretary. He's got a very, very busy center. He's a retina surgeon. He's an alumnus of Shankar Netralia, and he's practicing in Trichy. And he's very, very knowledgeable both in medical and surgical retina, and also very good experience with diabetic retinopathy also. I'm sure his inputs as far as the diabetic retinopathy and diabetic eye disease will be very valuable for all of us. I don't have to say about Dr. Muna Bende. I would say she is a person who is very, very difficult to see, a person who is good in all aspects. That is clinical, surgical, research, teaching, everything. And Muna Bende is, I would say, the star as far as the diabetic retinopathy or retina is concerned. She is the head of the VR department along with Pramod Bende in Shankar Netralia, my alma mater. Very happy that Muna Bende is here with us. She's got excellent, lot of research done on diabetic retinopathy as well, and her inputs will be very, very useful for all of us. Then we have Dr. V.R. Saravanan, guy who is really making a very huge mark in this part of the world, I would say. He is the head of the VR surgery in Aravind Eye Hospital, Coimbatore. Very knowledgeable person, academically very, very strong. A lot of papers published by Saravanan. Very innovative guy also. He's come out with the new techniques, and very happy that Dr. Saravanan is here with us to take it forward as far as this webinar is concerned. So with these few words, I hand over this thing to our secretary. Dr. Madhavan is there. Even our president-elect, Dr. Ramakrishnan, is already logged in. I would like him to say a few words, otherwise Dr. Madhavan to say a few words, and then over to the first speaker. There's a slight change in the order. Dr. Kim will go first, and then followed by Dr. Vijay Vishnathan on his keynote. Dr. Madhavan, our dynamic secretary of Tnoa.
Sure. Sir, good morning, sir. Good morning. And dear President and respected speakers and panelists, a very good morning to you all on the occasion of World Diabetes Day. For the past 2 days, Tnoa has been shining in the firmament of the cloud of firmament of the occasion. And 2 days back, we had AMS conference on bridging the gap between diabetes and diabetic retinopathy. And yesterday, we had a conference on innovations. And today, we are joined for Crusade against Diabetic Eye Diseases. So Tnoa has come out with an initiative for 1 month of diabetic retinopathy screening under the guidance of our president, the dynamic Dr. Mohan Rajan, for the screening of diabetic retinopathy in collaboration with Indian Medical Association, diabetologists, general practitioners, and with a theme of availability, accessibility, and awareness to all members and public for the next 1 month. And we would like our members to join in this effort and give us some documentation which we can forward to the national IMA also, and which will be helpful in policy making and decision making. And with the presence of such dynamic and energetic president, we can look forward to many more such initiatives in the future also. And so Tnoa is indeed shining, and shining for the right reasons. And I hope we'll have a wonderful educative program today, which will benefit all our members of Tnoa and also the members, because Tnoa has been the gold standard for ophthalmologists throughout the country. And we will stand, today's webinar will also be heard in the nook and corner of our country. Thank you. Thank you for the wonderful opportunity. Dr. Ravi Shankar, over to you.
Yeah, thank you, Dr. Madhavan, for the nice words. I think, as you know, we have launched an initiative along with the IMA, and this initiative is not only for TNA members, but across the all members for the All India Ophthalmological Society, and even for the general practitioners as well. That is the 3 A's: create awareness, create availability, and create accessibility to diabetic eye screening for 1 month from November 14th, that is today, to December 15th of 2021. And this is a new initiative we are taken up. Every year we know that it's doing, but we need to create awareness so that people to come to us early so that we can diagnose early, because treatment modalities are much more effective when we diagnose diabetic retinopathy or diabetic eye disease much earlier than normal. And then over to the first speaker, and I request Dr. Ravi Shankar, moderator, my co-moderator, to take over the proceedings.
Very good morning. Vanakkam, namaskar. And it is indeed a pleasure to be here as a co-moderator in this wonderful crusade against diabetes. And thank you, President, for giving me the opportunity. And this year, the theme of the World Diabetic Day is access to diabetic awareness and treatment. Last year, I think most of the diabetologists and ophthalmologists will know it was actually nursing and diabetes. This year it is access. That's a good theme which the World Diabetic Association has brought in, and that's one of the reasons Tnoa today is creating this awareness and creating the access of to all general ophthalmologists, diabetologists, general physicians to know more about diabetic retinopathy. And may I have the pleasure to introduce the entire speakers of the day, and a very good morning to the faculty who have made it possible to be here this morning. And talking about the first speaker, a great human being, a very slow-spoken gentleman, the director and senior consultant of the Aravind Eye Care System, Madurai, a person who's very accessible and approachable, a person who's done a lot of work in tele-ophthalmology, tele-screening in diabetic retinopathy, and lots of work in diabetic retinopathy in the Aravind Eye Care System and surrounding Madurai villages. They have done excellent work. And I'm talking about none other than Dr. Kim Ramaswamy, who's a wonderful gentleman, who's been a great source of inspiration to many younger ophthalmologists, including me in this part of the world. And he's going to talk about telescreening in diabetic retinopathy, how much telescreening would help everybody to diagnose the disease very early and treat it accordingly. May I have the pleasure to introduce Dr. Kim Ramaswamy, and over to you, sir, for your talk. Thank you.
Thank you.
Now, I'll be failing in my duty. Kim, one word about you. I'll be failing in my duty about Kim. Kim
Yes,
and Usha. Kim, as you know, is a retina guy, and Usha is an oculoplasty orbit person. They are, I would say, the star couple, and I would say the superstar couple. And they have taken ophthalmology to a totally different level. And thank you, Kim, for joining this webinar.
Thank you, sir, for this very, very generous introduction by Dr. Ravi Shankar and you. First of all, I want to congratulate you for creating this and giving this importance to this very, very important topic. I think of late we are seeing a lot of importance being given to diabetic retinopathy, and I hope this will be making a big change in the way we treat patients. We hope we will soon have not to deal with these advanced stages of diabetic retinopathy, no surgical thing like in the West. I think we should achieve that. That's when we would have really achieved our goal. So thank you again. And I really like your logo, the Tnoa is shining. That is really, really, really very attractive and very encouraging for everybody. I hope, can you see my slides, sir?
Yes, sir. Yes, sir. Very
so
clear. Audio also is very.
So it's not full screen, sir. It's
it's not in full screen?
It's in presenter's view, sir.
Oh, I'm sorry. Just
Which show can you put?
I'll just 1 second, sir. 1 second. I thought.
Just put it in the show.
Yes, sir. What happens is it's in the two monitors, so that's the problem. So I thought this would work.
Yes, sir. Yes, sir.
Can you see now?
Yeah, yes, sir.
Yes. Okay, now you should be seeing the full screen. Is it seen, sir?
Yes, sir. Yes, sir. You have to go to full screen, that's all. Otherwise.
No, right now it's not in full screen yet, is it?
Not yet, sir. Not yet.
You're not able to see a screen.
No?
Again, it's in presenter's view, sir.
Oh, sorry.
No, you do one thing. You go back to the original one wherein we can see the slide. We can advance that.
Doctor, you have an icon called swap displays. I think it will help.
Yeah, what happened? I know that's what I tried changing, but it's coming back to this one. That's what I did.
We can go like this. No problem.
Okay, sir. Sorry about that.
Yeah, no problem. Yeah, it's good enough.
Okay. So today my talk is on telescreening, and then the recent presentation from the IDF, the data shows that there are globally 537 million, which is much more than what was presented earlier, like 467 till now. But this is the recent data from the International Diabetes Foundation, which shows a gross increase in the number of diabetics, which is also sad to see that 4 in 5 adults with diabetes live in the low and middle income countries, which means the economic burden for these countries because of this is going to be huge, not only because of diabetes, but also the complications of diabetes, such as diabetic retinopathy. In India, we have about 77 million people living with diabetes, and it is expected to double in the next 25 years. This means that we are going to be facing with all the problems or complications of diabetes over a period of time. The data regarding the number of diabetic retinopathy, we have most of these studies from the southern states. It ranges from 12% from the rural areas to almost 18 to 20% in the urban areas. That is the number of diabetic retinopathy among the diabetics, which means it's a huge problem. 1 in 5 a diabetic is having some retinopathy. The Essen Dreams had shown that there are about 6 million diabetics, and of these, 1 in 3 diabetic retinopathy will have diabetic macular edema in the urban areas, while in the rural it could be 1 in 5, which again poses a huge public health challenge and a financial burden for our country. Unfortunately, this is one area neglected by the physicians. Very few people practice using direct ophthalmoscopes. And one of the studies showed that the barriers to this is because of lack of time or lack of training or lack of awareness about diabetic retinopathy. But screening should not be limited to the ophthalmologist. So it is important that the screening is also done by the physicians, either using direct ophthalmoscope. But more importantly, I'm going to talk about how this can become much easier for them using technology, what we call as telescreening. So I call this as an opportunistic screening to screen the diabetic patients, because the physicians or the endocrinologists or the diabetologists are the first point of contact for these diabetics. And they do not reach out to the ophthalmologist, but they definitely go to the diabetologist for their diabetic problem. So just like they get their blood investigations done, they should have their retinal exam also to rule out diabetic retinopathy by simple taking of fundus photographs. The fundus images are taken by their own technician. One of the technicians can be trained to take a fundus photo, transmitted to a reading center, where a retina specialist or a trained grader can look at these images, grade them, and send a report back to the diabetologist clinic, where the diabetologist can counsel the patient on further management. We have been doing this for almost 20 years now. Since 2001-2, we started doing this. We are doing it with quite a few diabetic clinics around Madurai. For the last few years, we have been also, with the help of the government, primary health centers, where our mobile van goes to these primary health centers, where the patients come to collect medicines, because the diabetic medicines are given once a week in these primary health centers. And the physician there ensures that every single diabetic person gets their eye examined through this process, and only then they issue the diabetic medicines. This ensures that every patient gets their diabetic medicine, their eye examined during this process. But what are the challenges? There is, to have trained graders is not easy. The retina specialist time to be spent on this would be a total waste of time, because of the demand on the clinical side is much higher. The process involves about 1 to 2 hours. Also, in some of the studies, it's been seen there's a lot of inconsistency in grading by different people. So LV Prasad Institute had done a wonderful work by developing this tele-DR screening curriculum for non-ophthalmologists, so that they learn how to take fundus photos, they learn how to grade these images, and all to the recommendations. So they go through a complete training period over 7 months, and then they get these people certified so that they can work in multiple areas and do these retinopathy screening independently. Well, with the advent of artificial intelligence, things have started changing. Diabetic retinopathy is the first condition in which AI was used in any healthcare diseases. The first one, because this was a low-hanging fruit, image-based diagnosis. So almost throughout the world, people have been working on AI algorithms. It's as simple as, just take a picture, immediately within a few seconds, the algorithm throws out the grading of the images, whether it is moderate, mild, or whatever it projects them. So today, we are using this in real time, because these are CE certified. We have started using this AI tool for screening our diabetic patients in the diabetic clinics and other areas. And the turnaround time, within a few minutes, few seconds, the patient is able to get his report, and the doctor is able to advise the patient further on as to whether he should see an ophthalmologist or to come back in the next year. There are any number of AI algorithms, more than 100 that is there outside. These are some of the popular ones that are commercially available for people to use. So this is going to be the way for screening these patients. We have been using these Google's AR algorithm in real time. There are many types that AI is using. One is the online, where there is a need for internet for the images to be uploaded into the cloud and receive the reports, and the offline ones where the algorithm resides in the camera itself with no need for internet. Each one has its own pros and cons. Regarding the grading, most of them do a simple grading, either no DR or a referable DR, whereas some of the advanced algorithms are able to grade these images based on the classification in which it was developed, such as ETDRS or the recent advanced classifications that is available to either mild, moderate, or severe NPDRs. For the real-time implementation, as I mentioned, we have been using this in all our screening programs where we are using, we've been doing this DR screening for these so many years. We are slowly using AI in many conditions. In the last 28 months, we have screened about 56,000 diabetics. Of these, 21% of them were diagnosed to have diabetic retinopathy. This is being done by most of the institutions recently. Dr. Shankar Netralaya started DR screening along with us around, again, about 2 decades back. They've been also going into the community, taking the fundus camera. And then once the pictures are taken, they do a video conferencing with the doctor at the base hospital. And the doctor looks at the image and then advises the patient on further treatment. Mohun Diabetics Research Centers Research Foundation is doing excellent work on this side. They've been using telescreening or telemedicine for not only diabetic retinopathy, but all the other complications of diabetic retinopathy, but more importantly, all complications of diabetes, more importantly, on diabetic retinopathy. Dr. Rajalakshmi has been doing an excellent work in this. She's been making a lot of efforts or research in this activity, trying out with different fundus cameras. And recently, she has been working with these phone-based cameras, smartphone-based cameras, and using an offline AI. She's been using this in the field to screen diabetic patients, and they're doing an excellent work. Where in one of these, this is the recent data from 2018, where they had screened people with diabetes, and they found 31.9% of the people having diabetic retinopathy. Dr. Natarajan, another person who's been raving about the importance of diabetic retinopathy and diabetic retinopathy screening, has been doing a lot of work in Mumbai. His team has been working in the slums of the Dharavi, screening the diabetic patients there using different fundus cameras. And off late, he's also been using these smartphone-based AI-linked DR screening in the community, which is making a huge change or identifying these patients early on. So telescreening can play a major role in the early identification of DR patients, but more importantly, the need for awareness and the onus of identifying these patients. I repeatedly keep saying it's not the ophthalmologist, but it should be the physicians and the diabetologists who should have the responsibility of identifying these patients early on, because this can be done seamlessly using technology that is available today. So once we do this, we can identify all the patients early on so that they can be only those who have any retinopathy needs to be referred. Today, we are getting to see all the patients with and without retinopathy, but this way of identifying these patients or triaging these patients will help both the physicians, the patients, and the ophthalmologists to bring these patients early on so that we don't have to deal with the advanced stages of diabetic retinopathy. So definitely technology can play a major role. And with the advent of AI, not only in screening, this is going to play multiple roles in many areas. I think this will become a reality soon. So thank you, sir, again for this wonderful opportunity to share our thoughts on this. Thank you. I'm sorry about the slides.
You need to unmute, sir.
Sorry, can
You
you?
need to unmute, President.
I'm sorry. Thank you, Dr. Kim, for the fantastic overview and on telescreening and diabetic retinopathy. And we all know that the telescreening is very, very important as far as the diabetic retinopathy is concerned. And I know you are the forerunner as far as the artificial intelligence in diabetic retinopathy is concerned. Along with the Google, you have been doing a lot of work on that. I'm a little, surprised or shocked to find out the incidence of diabetic retinopathy is close to 31% in one of the studies by Mohan Diabetes Center. So we'll go to the panelists now. Let me ask.
Sir, sorry to interpret.
Yes.
It's not the incidence. It is you have to understand that when the diabetic screening is done, it's the diabetic patients who are coming in and they are being screened.
I know.
So it's mostly people with advanced diabetics, and these people who are being handled by any diabetic center. So that's why the number is very high.
That's right.
Yeah.
Normally, the normal teaching is that 20% of the diabetics will have some evidence of diabetic retinopathy. 31% I thought was a little high. That is the reason why I asked. Let us go to the panel discussion now. Let me ask Dr. Muna. Muna is here? No. Yeah.
I'm here, sir. I'm here.
Muna, what's your take on this particular talk by Dr. Kim, and what's your opinion?
Yeah, I'm not using my video because I have a bad internet. But Kim, a really nice talk and sharing all the information that we have and the potential for telescreening. And it's a good initiative. Our only problem sometimes is when you pick up these patients in these telescreening camps or in the periphery, getting them to the doctor for treatment and getting them repeatedly is the challenge. They will come once. But the issue is getting them back, supposing you want to give them an injection, getting them back every month in the middle of all their other problems. Sometimes that is a challenge. And if a patient has 66N6 and very bad diabetic disease, which is a possibility, convincing them is also an issue. So I think that is the biggest challenge that we face right now.
How do you tackle that, Sir Kim?
Yeah.
My main thing is not just in the outreach. Of course, the idea is to identify these patients and screen them early on. But more importantly than the next step, it has to be a full spectrum, meaning not just identify and leave them, and you bring them the first time. As Dr. Muna said, they don't come in. It happened. This compliance problem is there even in our patients who come to the hospital. So you need to, especially for these people who are coming from the lower, who are found in the camp, you need to have a lot of awareness or counseling to be done to these patients. And that's where your focus comes. So as I said, it's not just enough to screen these patients. It's important that we provide the full spectrum. Identify them, make sure that those who need care have access to care at some location, and thereon counseling and all that has to take over. But my interest was also to insist on the physicians taking over the screening. That's where we will play a major role, triaging the patient, because I've spoken to Dr. Vijay about this earlier on. And in all the diabetic forums, we try to speak about this. But unfortunately, the take-up from there is not very high because they don't have to even do anything.
Yeah.
Dr. Sendil had done a wonderful way of doing a telescreening. He made a business model out of it, and he was able to screen 18,000 diabetics every month, which no other program has done. So,
yeah. I'm glad that Professor Shantaram has joined us now. It is the correct time. Professor Shantaram, I just introduced you before you came, sir. I know you are the colossus of diabetology in this part of the world. And I want your opinion, sir, because the normal feeling among the specialists is that the physicians are not creating some sort of awareness, because they are the first point of contact when a diabetes patient goes to them, because they are the first point of contact as far as diabetes is concerned. And subsequently, the physician has to refer the patient to the ophthalmologist or the nephrologist or the cardiologist or whatever it is to take care of the complications. Sir, your views on this, sir?
Sir, very good morning to all of you. Until I agree with what you have said, it is the physician who has to sensitize the patients regarding the modalities of evaluation and has to refer the patient at the right time to the specialist. So, for example, a patient coming to the diabetic clinic or to the physician, if everybody has to be examined with ophthalmologist, it puts a great workload on the ophthalmologist and the quality of care may come down. So if you, as Professor Kim has said, you triage the patients and send them after detecting diabetic retinopathy, it will be more appropriate. For this, you have to have a continuous medical education to sensitize the physicians. But one thing you see, what happens is it is time consuming in a busy clinic. Sometimes physician may not have the time to do everything by himself. So what I would suggest is we have to integrate the tele-ophthalmology into this so that there is a wider access and screening can be done at a shorter time and can be done by a non-ophthalmologist also.
Yes, sir.
So not necessarily should an ophthalmologist do it, none of them can train, none of them can screen, and they can pick up, and if further opinion is required, they can refer to the concerned specialist.
Absolutely, sir. I think you hit the nail on the head, because it can be done by the technicians, the paramedics. All these people can be trained to just do a smartphone fundus photography. Dr. Saravanan, your views on this?
Yes, sir. As regards to the percentage, I think the Mohan Center's cure study, Chennai urban study, showed approximately 13 to 15%, if I'm right, about the incidence of retinopathy amongst diabetics. But anyway, as regards to the screening itself, unlike the European countries, we have a long way to go. And I think individual hospitals will not be able to achieve this. I think the government should chip in, including all the primary health centers and all the their government hospitals. And the issue of proper hardware as well as cloud-based AI detection should be the way to go. Unless the government chips in, this can never be conducted in a big scale, sir.
Absolutely, sir. I think it's a point well taken. Sriram, you have anything to say, Sriram, since you have joined?
Sorry, sir. Sorry for joining late. I was caught up somewhere. No, this is just the same points we made in that meeting on Friday, sir. Mohan
Yes.
sir will remember. See, traditionally, when I'm seeing patients with severe diabetic retinopathy, I'm not talking about just detectable or non-vision threatening. Real end-stage disease. These patients are generally not under the care of a proper physician or under the care of a proper diabetologist. Most of our programs right now is keeping these cameras and screening these people in places like this. But fortunately or unfortunately, those places, the patients don't get that severe retinopathy because the diabetes is taken care of them. So it is the semi-urban and rural areas where people don't have access to a good diabetologist or physician. It is those people who need the screening more, because invariably it is those patients who come with very severe, almost blind in both eyes. So like we are talking in that meeting yesterday, we should try to diversify this and take it to other places of contact other than diabetic treatment hospitals, like opticians and things like that.
I think it's a model which has been taken up by Singapore, wherein they have kept a fundus camera in every optical shop and optometrist. And I'm not sure whether you are aware of the NHS system. That is also a very good system, the robust system, which takes care of the diabetic retinopathy screening across the UK as well. So I think we have a lot of things to learn in this. It's a learning process. Thank you, Kim, for the wonderful insight, I would say. And you have set the ball rolling for the very nice webinar. If you can stay for a few more minutes, then you can probably leave. Then we'll go on to the second lecture by the keynote lecture by Dr. Vijay Vishnathan. Over to Dr. Ravi Shankar to introduce Dr. Vijay.
Thank you, sir.
You're
Ravi?
muted. You're muted.
Muted, Ravi. Unmute. Ravi, unmute.
Yeah, sorry about that. I did unmute now. And my salutations to Professor Dr. Shantaram for joining us this morning. and Dr. Sriram Gopal, the Joint Secretary of Tnoa, for joining us. Thank you. And it is indeed a pleasure to introduce the next speaker online, who definitely doesn't need introduction, but it is my pleasure to introduce more and more about him, which I would love to do it. This gentleman comes from a family where diabetes is in their blood, and it's in everybody's blood in and around Chennai and many parts of Tamil Nadu. And he as an individual is working so much on diabetes, not only treating diabetes, but on the prevention aspect. That is very, very important. Number one, the access to diabetes to people in Chennai and surrounding Chennai. And number three, his stronghold is diabetic foot treatment, the rehabilitation, not only the treatment aspect, the rehabilitation part, which I've heard him talk regarding the diabetic foot and rehabilitation in almost 3 to 4 seminars and workshops earlier. A person whose father is none other than Professor Dr. Viswanathan, the father of diabetology in this part of the world. And Dr. Vijay Viswanathan is a proud person who's continuing the legacy started by his father way back long time, and now being the chairman and the medical director of MV Hospital, the diabetic hospital in Chennai. And he has multiple branches where I would appreciate his work the same as his main branch. That's what we were associated with the Mylapore branch in Chennai for many years, and we understood the treatment was same as the primary branch. That's the greatness about this gentleman, a ground level worker for diabetes, presented so many seminars, presented so many workshops internationally too, and may I have the privilege to introduce Dr. Vijay Viswanathan, an unknown professor, an untold hero of diabetes in this part of the world. Over to Dr. Vijay Viswanathan.
Yeah, thank you, Vijay. I think, Vijay, as Ravi said, everybody has got glucose in their blood, but it is very rare to see diabetes in their blood. It is only the diabetic gene which is running in the blood for Vijay Viswanathan, and he can nobody can be better than him. And also, I think he's the president of the Asia Pacific Diabetic Association, if I'm right, Vijay, or the Asia
president of D-Foot International.
Yes, International, the Asia Pacific is the president. Very, very honored, Vijay, to have you.
So thank you, Ravi Shankar, and thank you, Dr. Mohan Rajan, Dr. Sujata Mohan, and the entire Rajan Eye Care for this honor. My respects to my senior colleague, Professor Shantaram, sir, who was the Vice Chancellor of Tamil Nadu, Dr. Indian Medical University, and also my all senior colleagues. I'll take only 10 minutes and I'll share my screen.
Yes. Slideshow, can you put?
I'm just trying to share. Yeah, I don't know where to share. First, yeah, share. Okay. It's asking share, sign in to share your presentation.
No, it is, we are able to see the screen. Slides.
You're able to see?
Yeah. Only put slideshow.
Okay. Slideshow, I'm not even, I tried to show the slideshow.
Bottom.
You just press F5, sir. F5 should be enough in your system.
You can see the slides now? No.
No, you stop sharing now.
You can see now?
In your right-hand bottom corner, sir.
Can you see the next slide?
No, I'm able to see, but we're not.
We can see the slides, but it's not in slideshow.
Slideshow. Go to the bottom. Yeah, that's right.
Yeah.
Just that.
Just wait
So
for a second.
take 10 minutes to talk about prevention of diabetes. And at the end, I'm going to say it's a hope, it's not a hype. So that's what I'm going to say. And we all know that diabetes is not just an endocrine disease, a metabolic disease, but it is a vascular disease. It affects almost every blood vessel you can think of. So John Cockcroft said diabetes is not an endocrine disease for a metabolic disease. It's a vascular disease. Now, it's very costly. And we did this study some 11 years ago. This was the first study in India where we showed that the cost of diabetes care was about 1,541 billion Indian rupees. And we also showed that as the number of complications increases from 1 to 2 to 3, the cost goes up. And it's very important that the cost not only goes up for the patient, but also for the primary caregiver. So supposing the wife is admitted, the husband has to look after her in the hospital, the son or daughter does not come. Or the mother is admitted, the son is in the hospital. So there is a number of loss of man days, median income, not only for the patient, but also for the primary caregiver. So it's a very costly disease. So we should try to prevent it. So now in the next 8 minutes, I'm going to tell you why some people develop diabetes complications and some do not. For this, I think this basic understanding is very important. This is a day on which you diagnose diabetes, 0 point. But diabetes type 2 especially does not start at this point. It starts at least 10 years before the person is diagnosed with diabetes. Because you can see during the first 10 years, minus 10 years, the insulin resistance has already set in, the insulin secretion has already become defective, the postprandial glucose starts increasing, the fasting starts increasing. The complications also start off at least about 5 years before, and macrovascular pertaining to the heart occurs at least 7 years before you actually diagnose them. So it's quite you can say you're missing the bus if you diagnose diabetes here and start treatment here. So the clinical inertia which we have in India and abroad should end, and we should start screening more people for what is called prediabetes. Because we showed that in this paper, in 11 years follow-up study, we've showed that if you have a 1 hour value, the fasting is normal, 2 hours is normal, but your fasting is normal and the 2 hours is normal, but your 1 hour reading is above 165. It's called prediabetes. And this is what Professor Vishwanathan called it as the early glucose intolerance. This is one of the earliest changes which you can detect in diabetes, in prediabetes. And the risk is about 7 times more if you have an elevated 1 hour post GTT, but with the normal fasting in 2 hours. So you usually make a diagnosis of diabetes only when the fasting goes up above 126 and the 2 hours above 200. But if the 1 hour reading goes above 160, then you are facing a situation which is called prediabetes. Now, after the hyperglycemia sets in, a number of metabolic pathways are triggered off, and that leads to what is called a perivascular fibrosis. And this is the key slide in my talk. There is a point of no return where perivascular fibrosis sets in, and after that, there is no point in controlling diabetes because the complications are set in and they just go on and just keep going on forward. So this is a new concept called metabolic memory, which is very important for the title of my talk, which is called metabolic memory, wherein if you reduce your HbA1c from 8.5 to 7 and keep it at 7 from 2 years and up to 11 years and beyond, then you will not get complications. Whereas if you don't keep your diabetes under control after 2 years after diagnosis, the complications set in, and this is called a bad glycemic legacy, and you'll get a lot of complications, which is shown here in the pink color. Now, there are a lot of genetic factors involved. We showed in 1999 that there is something called familial aggregation. If you have one brother who has diabetic kidney disease, your other brother or sister can have diabetic nephropathy, is what we showed. There is a particular gene called ACE gene on chromosome 17. And if you have a particular genotype called the deletion allele, if you're homozygous for the deletion allele, you can get a greater fall in eGFR. We also showed this in 2 studies, one with collaboration with the United States, with Kumar Sharma and this group in Thomas Jefferson University. And we also showed the deletion allele in people with low eGFR. in our own center. So the age gene polymorphism seems to be an important factor. We also looked at another gene called the TNF-alpha gene, which increases the levels of TNF-alpha, which is a bad cytokine. And we found that as the kidney disease increases in terms of albuminuria, the TNF-alpha levels increase. Having said that, there is a strong genetic component and all that. We did this 12 years observational study, which we published in the Journal of the ICMR some years ago in 2012. And we found that what actually determines you from getting kidney disease is your baseline HbA1c, the HbA1c on follow-up of 12 years. And if you have diabetic retinopathy at onset, in the beginning, if you have the presence of diabetic retinopathy, your kidney progresses fast. Therefore, it's very important to diagnose diabetic retinopathy, not only to save the eyes, but also to save the kidneys. That's the important point. In the last two slides, my favorite area is the diabetic foot. Even here, there is a lot of hope. See, this patient comes to you with an ischemia, and almost everybody will say you have to do a below-knee amputation. We do an angioplasty to the posterior tibial artery and the anterior tibial artery and establish the blood flow, and then do debridement. And then we keep on doing what is called a VAC therapy, negative pressure wound therapy, and finally put a skin graft. So you can see that the wound is healed after about 1.5 months from this state to this state. So you can save even the worst of the foot if you know that a problem is there early and acknowledge it. If there is a leak, you detect it early and don't wait for it to leak too much, where even a cloth will not be enough to stop the leak. Therefore, my last slide, these are the challenges of managing diabetes in India. Most of the Indians take a high carb diet, so their blood sugars are never under control. They have very high postprandial blood glucose levels after food. Patients don't like the word insulin. They keep on trying tablets, and never go on to insulin therapy. Physicians have limited consultation time, and we have to spend time on telling about the benefits of insulin, controlling diabetes. And as Professor Shantaram said, we have to also screen for retinopathy, kidney, and foot. And there's a need for convenience also. So I'd like to thank Dr. Mohan for this invitation to speak. And I hope I could convey some message to you in the last 10 minutes. Thank you.
Thank you. Thank you, Vijay. You're able to hear me? Yes.
Yeah.
Thank you, Vijay, for the nice lecture on the, the complications of diabetes and how to prevent it. You've given a lot of hope. And it was seriously amazing to see that foot gangrene becoming all right completely with the treatment, which is possible today. And you are talking about the, we'll go on to the panel discussion. We're talking about the metabolic memory, okay? Which means that the first 10 years is very important. If you have tight control in the first 10 years, then you are unlikely to get any of these complications. But you are also saying that in type 2 diabetics, it's already 10 years before we diagnose it. So how exactly you tackle this problem? And I will go on to Professor Shantaram first, since he's the diabetologist in this panel. Professor, sir, I want your opinion on this, sir. Because the metabolic memory and your diagnosis. See, you are diagnosing type 2 on, you think it's day 1, but it's already 10 years according to Vijay. So how do you take it? How do you create that awareness, sir?
Yeah, Dr. Vijay, an excellent, useful topic, not only for the diabetologists, the diabetic, but also to the general public. It's an excellent topic, and you have conveyed the message in a very crisp manner, which everybody can understand. Regarding that, see, we have to diagnose dysglycemia before the diagnosing diabetes. That's what Dr. Professor Vishwanath has conveyed, Vijay has conveyed now. So, ethnically, we are more prone. So, any Indian above the age of, now the onset of diabetes is reducing, the age of onset is reducing. So any Indian above the age of 30 should do annual screening, even if there is no family history, so that you can detect diabetes early or the dysglycemia early. So as Dr. Vijay has said, the 1 hour is very important, which their centers clearly showed with the early abnormality of glucose intolerance, the risk of diabetes is much higher than with pre-diabetes. And second thing, there's one more thing I want to add is, see, it's an observation from me. I think Dr. Vijay would have done a study, or probably he has to highlight on this thing. We had seen a lot of patients, sugar, glycemia in the normal range, both fasting and PP. But whereas when the PP is less than the fasting, even within the normal range, these patients are more prone to develop diabetes because they are overreacting and the beta cells are producing more insulin, and the overreacting beta cells ultimately fails and the sugar goes up. So we normally advise such patients to go on a diabetic diet with a small frequent feed, even if the sugars are within the normal range. This is one thing. And there is something about the evening glucose tolerance. There are some people who are glucose intolerant in the evening with the same 12 hours fast. When that patient has got a overnight 12 hours and do a GTT, it remains normal. This was in the old Ellenberg shares that. That's a pre-diabetic phenomenon. So these are some of the ways where you can pick up. And there is an interesting criteria also, which is not clinically practicable. That is the Sipperson's criteria, where you take a buccal mucosa biopsy and see the basement membrane thickening. That becomes thickened even before the true onset of diabetes. That is also in one of the old books. I think Dr. Vijay can highlight on these things.
No, I think all the points are very valid, sir, what you said. And I think some people, they develop hypoglycemia by about 11 o'clock, reactive hypoglycemia. What the point you were trying to say? The blood sugar suddenly falls after breakfast. And when you do an extended GTT, you will see that the sugar goes to 60 after 3 hours. That's because of hypersecretion of insulin. The beta cells are trying to hypersecrete insulin in response to insulin resistance. So they go into what is called reactive hypoglycemia. So they take a lot of sugar and they become diabetics. So we tell them not to take sugar. When the sugar drops around 11 a.m., 12 mid-noon, when the sugar drops, they take a lot of sugar because they get low sugar. So I think your point is well taken, sir. Perfect. It shows your tons of experience.
Well, what do they take then? They go in for a reactive.
You have to give them a breakfast which is split. So they take 2 idlis at 8:30 and 2 idlis at 10 o'clock. Mm-hmm. And then they take around 12 o'clock some low calorie drink. You can advise any low calorie drink. You have a lot of protein diabetic supplements now available.
Okay.
I'm not naming them, but you have. So, and tell them take early lunch. Around, don't take it at 2:30, take it around 1:30, 1 o'clock, 1:30. So split the breakfast, have a drink, protein shake or whatever at around 12 o'clock, and have an early lunch. Don't take sugar. They go on taking sugar and
yes,
they get obese and get diabetes.
Well, normal teaching is that when they get into hypoglycemia,
this hypoglycemia is different. It's a reactive hypoglycemia.
Yeah. Okay.
This hypoglycemia is different. It's reactive hypoglycemia. It's before diabetes.
Before diabetes. Okay. Muna, your thoughts on this?
Sorry, sir.
Your thoughts on this talk, Vijay's talk?
Yeah, I think Dr. Vijay Vishwanathan has very nicely explained a lot of things to us in a very simple manner. May I ask a question, Dr. Vishwanathan? Yeah, you showed us you showed us very nicely about how you manage the diabetic foot. Now, suppose this patient also required surgery for retinopathy. What would you suggest? Because this is something we very often face, the severity of the retinopathy and as well as the coexistence of a diabetic foot. Would the presence
I think there is absolutely no problem. You can go on with whatever management you want for the eye, irrespective of the foot. In the kidney, even with a creatinine of 1.7, I tell people just go on. Don't be worried about the kidney. The kidney knows how to look after itself. Don't give drugs which are bad for the kidney. Don't give painkillers. Don't give pantoprazole and all that. But you can go on with your fundus fluorescent angiogram or whatever you want. Don't worry about the kidney. The creatinine might increase from 1.6 to 1.7. We do angiograms right, left, and center with people with mild CKD. Nothing happens. So if I look at the CKD, then I lose a leg. So I don't care. With a creatinine of 1.7, I just go ahead and do a peripheral angiogram and angioplasty, and tell the patient, if the creatinine goes up, I'll do some 1 or 2 couple of dialysis for you. So that's it. But I can't lose your leg. I need to save your leg. So I don't think there's, Dr. Muna, there's any problem in doing any of your procedure with a bad foot infection or even with CKD.
Okay. That would even apply to our intravitreal injections.
Yeah, absolutely.
I was wondering, yeah, Muna, as an extension of the question, I want to ask you, Vijay, whether it's when you have open wound there and we are doing an intraocular surgery like a cataract or a vitrectomy. So we are a little apprehensive about it. That's the reason why we are asking the question.
No, only Mohan, just make sure he's not in sepsis. Because many patients with foot infection have a total WBC count, which is very high. So treat them properly, make them non-infective. You can't make them non-sterile. I mean, if you do a culture, you'll still grow organisms. So if you find that your total WBC count is okay and there's no sepsis, signs of sepsis like fever or anything, you can go ahead. And if the podiatric surgeon is already managing the foot problem, there's no problem. You can go ahead and do what is necessary. If it's cataract surgery, you can wait for a month. But if it is vitrectomy and the fellow is blind, you can go ahead and do it.
Yeah, sometimes they come with a hypermature cataract, secondary glaucoma. We had to do as an emergency, and they have.
You can do it.
Yeah.
You can just tell your podiatrist.
Can I make a point here, sir?
Yes, sir. Sriram, yes.
No, sir. With regards to the fluorescent angiogram, I think what we need to remember is fluorescent is actually not a nephrotoxic dye. So whatever the renal status, ideally there should not be any contraindication to do a fluorescent angiogram. It is cleared by the kidneys. If your renal function is not good, it's going to take more time to get cleared. Fluorescent, as opposed to the dye used for a coronary angiogram, which can raise your creatinine levels, fluorescent angiogram, there have been multiple reports that it does not increase your creatinine levels or your EGFR levels. It's not a nephrotoxic dye. It is cleared by the kidneys, but doesn't mean it's bad for the kidneys.
Okay, we can still go ahead to the.
Can I have one comment here, sir?
Yeah, Dhanashree, please.
Yeah, excellent talk, Dr. Vijay. I really enjoyed listening to your talk. And I am so happy that you touched upon this topic of pre-diabetes. And so we did some short study on pre-diabetic changes, retinal changes in pre-diabetes. And we published among the very first reports of retinal changes in pre-diabetes. So what we found that there were no apparent clinical changes, no microvascular changes and no vision changes at all in pre-diabetes, but there were early neurodegenerative changes were seen in the form of changes in the multifocal ERG and a subtle change in the macular thickness, which tells you that there is some early change in the ganglion cell layer. So, and later on, probably, as you said, after 5-10 years, these patients may develop frank diabetic retinopathy and diabetes disease. So, what I would like to ask you is that what is it that changes this situation from pre-diabetes to diabetes? Is there kind of some stimulus, and do you think that it can be reversed with some lifestyle changes? And of course, another corollary to that is whether the retinal changes would be reversed if we are successful in reversing the pre-diabetes stage.
The pre-diabetes, we have fantastic data from the US. Lifestyle modification and losing weight can reverse pre-diabetes. I'm sure Professor Shantaram sir will agree. So lifestyle modification is the first thing to be done in pre-diabetes. We do use metformin in people who are very obese with a BMI above 30. We do use metformin. But the first thing is lifestyle modification. They have to be physically active and lose weight, especially the central obesity, and do some resistance training and improve their sarcopenia. The Indians have sarcopenia. They're called thin fat Indians. Muscle mass is very less. So this is what we do in pre-diabetes. Diabetes, the stage of microaneurysms and microalbuminuria is reversible. But once you go beyond microalbuminuria and microaneurysms, it's not reversible. Even if you control diabetes, unless you control the first 2-3 years. I'm sure Dr. Shantaram sir will agree that lifestyle modification is most important.
Dr. Vijay, even studies have shown, even the conversion is much less to the lifestyle modification than with metformin or the other drugs which are used to prevent. There are so many drugs they are using, the pioglitazone, metformin, ARBs, so on and so forth, to reduce, to prevent the pre-diabetes to diabetes. But as Dr. Vijay said, it is the lifestyle modification which has given the highest success rate with respect to preventing the conversion from pre-diabetes to diabetes. And even among diabetic, lifestyle is the cornerstone of therapy, because we do not have drugs to slow down the progression or prevent the diabetic specific complications. We have drugs to control only the blood glucose values to prevent the assault on the blood vessels. So to slow down the progression, lifestyle is the most important thing, so that you will stay on minimum drugs for a longer period of time.
Sir, what exactly is the lifestyle modification? Can you just specify, sir?
Yes, it is the physical activity. So 30 minutes of 150 minutes of walking per week is enough. So whatever you do, it has to be consistent. If it's inconsistent lifestyle, you have a lot of fluctuations, and the glycemic variability is as harmful as high glucose exposure. So see, some people burn out, they do 1 hour a day, the next day they don't do it, the next day they do it for 30 minutes. They produce a lot of glycemic variability, exercise induced. And similarly with diet, it is the diabetic diet, small frequent feeds. So with 50 to 50% carbohydrates, see all these things, the new diet, the paleo diets and the keto diets, you should look at the patient as a whole, not only as a sugar patient. And what is practical also you should do. See, I had a patient some time back who takes 8 spoons of ghee at 8 o'clock and 1 vegetable sandwich and nothing till the next day. How long you can survive on that? So whatever you're doing, it has to be practicable. So regular physical activity, timely food, spacing is very important. Quantity has to be consistent. You should take a low glycemic index foods. Then have good sleep in the night. That is also very important. So less than 5 hours, your sympathetic system gets activated. So it throws up, it produces dyslipidemia, increase in blood pressure. And your mental state, that is also very important. Then the vitamin D levels. Sun exposure is also equally important. People with vitamin D levels have more resistance. The resistance precipitates diabetes or conversion pre-diabetes to diabetes.
Sir, I'm glad you raised this point, because yesterday and day before yesterday, we had some talks in the IMA meeting, say about intermittent fasting, sir. This intermittent fasting that is controlling the diabetes levels in many people, because there are a lot of contradictory opinions as well, and the pros and cons of intermittent fasting.
Sir, recently there was a paper, see, omitting a breakfast will increase the insulin resistance. So intermittent fasting is good for non-diabetic. For diabetics, if you want to still do, you can do the 14 hours intermittent fasting. Normally we fast for 10 to 12 hours in the night. So you can have a giant dinner at 6 o'clock and have breakfast at 8 o'clock. That gives you 14 hours of fasting.
Okay. So that is good enough.
For diabetics.
Yes, sir.
Because that is the practical way of doing it. See, otherwise you'll have lot of glycemic variabilities, and there are papers. Recently there was a paper saying that skipping a breakfast will increase your insulin resistance.
Absolutely. Okay, Saravanan, your quick 1 or 2 thoughts on this.
You're muted.
Muted.
You're muted.
Sorry, nice points coming out of this talk. One is that the diabetic memory, that initial 2-3 years of control is going to do a lot of good in the following years. And as Gopal pointed out, the role of creatinine, that we don't need to be worried about doing fluorescein or intravitreal injection in these patients, even if the creatinine function is not that very adequate. There are some of the nice points coming out, and the role of lifestyle modification and pre-diabetes. So nice, lot of good things coming out of this talk. Great talk.
I think we'll go on to the next talk. Thank you, Dr. Vijay, for the wonderful keynote address and very good take-home messages you have given. I know you are an authority on the diabetic foot. And one final question to you before we go on to the next talk. You are able to get that foot back to normal. But what about the neurotropic, that is, it's a trophic ulcer, if I'm right. There's no nerve supply because of that only they're developing these ulcers, or because of ischemia. How do you get the
most important is the regular follow-up. We have to ask the patient to come every 3 months. And second point is offloading is very important. Just as you have a ready-made shirt bought from a shop, and you buy the cloth and ask your tailor to stitch it according to your tummy and all that. The footwear also can be made. The insole can be made according to the pressure point and so on. So customized insole will go a long way in preventing re-ulceration. many people wear only an MCR footwear and walk around. MCR is not a customized footwear. So your question, Dr. Mohan, is regular follow-up, good control of diabetes, and proper offloading.
Absolutely. I think
after healing.
I think these are all golden messages to prevent complications of diabetes. More importantly, it has to be a collective effort. And we'll go on to the next speaker, Dr. Ravi Shankar, to introduce Dr. Manoj Khatri.
Next speaker of the day is my good friend, Dr. Manoj Khatri, a versatile vitreoretinal surgeon who's been one of the top vitreoretinal consultants in the country today. I'm proud to say that. And he'll be talking about management of diabetic retinopathy. He is a senior vitreoretinal consultant of Rajan Eye Care Hospital and the medical director of IDOCS Eye Hospital. Over to Dr. Manoj Khatri, please.
Manoj, thanks a lot.
Thank you, sir. Thank you, Ravi Shankar. I hope my slides are visible and I'm audible.
Yes.
Okay, so a lot of good learnings and year on year when we are doing this World Diabetic Day symposiums, we are learning many management aspect of the systemic front rather than looking only at the retina and not ignoring the patient as a whole, as our traditional teaching is there. And very happy to be on the same panel right now today with my teachers, my gurus who have got me so far. So let's understand diabetic retinopathy, what is the evidence which is telling us and how we are going to treat it. No financial interest in my talk. What we have understood from previous talk is the problem is quite big, whether it is diabetes mellitus per se or diabetic retinopathy per se. And the magnitude of the problem is increasing day by day. We are going to have close to 700 million patients by the year of 2045. And out of that, 245 million patients worldwide are going to have some form of retinopathy, and almost 30 million patients are going to require some form of treatment. So to counteract this burden, we have to act now. We have to act today. The disease burden by far for both diabetic retinopathy, which forms two major counterparts, that is, one is a proliferative disease and the diabetic macular edema is also on the rise. And when we come to the treatment part, which first includes vision-threatening diabetic retinopathy, diabetic macular edema, and proliferative diabetic retinopathy, slowly and steadily these percentages are rising. We started with single-digit 4%, 5% when I was a postgraduate and a fellow, and now you can see we are reaching double-digit numbers in no time. Loss of vision is one of the most feared complications for any patient, whether it is a diabetic or a non-diabetic. More so for a diabetic patients, they will not go to a visit to a diabetologist, but they will always come for their visit to a ophthalmologist and radiologist, which has been sought after by many population-based studies. And when we compare, the diabetic macular edema score, which is significantly poor in quality of life tested than patients with diabetic retinopathy. And over a period of time, right from general health to their social function, mental function, over a period of time, this keeps decreasing. There are a lot of classifications for diabetic retinopathy per se, but what we commonly follow is a non-proliferative diabetic retinopathy disease, then which goes for a proliferative diabetic retinopathy if not treated, and diabetic macular edema, which can be center involving and non-center involving. Clinical features of PDR and DME, I don't have to tell this august audience, but just to benefit for other colleagues who have joined us on different forums, we normally consider as non-proliferative disease, which starts with microaneurysms, vascular leakages, formation of hard exudates, soft exudates, and so on. And any kind of neovascularization, that means the disease which produces new blood vessels on the surface of the retina, it turns out to be a proliferative diabetic retinopathy, which has its own further classification. When we come to the diabetic macular edema, this is the center of the retina, which is called as fovea, and it's on the OCT optical coronal tomography scan. Whether the center is involved or the center is not involved determines the treatment, main treatment horizon as of now. And over a period of time, proliferative disease, that is proliferative diabetic retinopathy and diabetic macular edema, can go hand in hand. And we are seeing, especially after this COVID pandemic, these entities are much more what we call potentially sight-threatening and as well as challenging on the treatment part per se, because these patients most often are not frequent follow-up, that is the monthly follow-up and so on, which is called challenging. Couple of points before we start with the management of diabetic macular edema. Let's look at the proliferative diabetic retinopathy, what the current literature and the practice tells us. When we see a patient with non-proliferative diabetic retinopathy with no diabetic macular edema, we just tell them that the risk factor control damage should be good enough. The goal of treatment is to just concentrate on the systemic parameters. But when the patient starts, especially if the patient is a one-eyed patient, we tend to, when the patient has a proliferative diabetic retinopathy, we either tend to balance between a pan-retinal photocoagulation, which is still the gold standard, and vis-a-vis anti-VEGF therapy, that is anti-vascular endothelial therapy, growth factor therapy, whenever it's required. Over a period of time, the threshold for doing surgeries for these patients at an early stage, it is called as vitrectomy surgeries for the surface of the retina, is becoming quite commoner, and as and when our experience is growing and with the non-invasive, like minimal invasive vitreoretinal surgeries, whenever we see any kind of traction, we are considering surgeries at a much earlier stage, even with a good visual acuity of about 6/9, 6/12, rather than waiting for the disease to progress. And also it depends on the stage whether the patient only has a tractional retinopathy or also has a combination of rhegmatogenous retinal detachment associated with it. Anti-VEGF therapy versus pan-retinal photocoagulation. This is the current hot topic of debate. That is what I have put this slide for today's talk. We tend to inject only anti-VEGF growth factor therapy along with pan-retinal photocoagulation in non-tractional type of cases. As of now, very little evidence is there how the vitreous is going to behave over a period of time, even there is a non-tractional proliferative diabetic retinopathy. But over a period of time, still the gold standard remains a good pan-retinal photocoagulation, which has to be done by a experienced person, I will say, because this kind of pan-retinal photocoagulation, if not really done correctly, can lead to problems over a period of time. DRCR.net, that is Diabetic Retinopathy Clinical Research Trial, has given us a lot of clinical algorithms, but all these things have to be tailor-made, that this has to be custom-made, and Dr. Vijay already said, even the systemic management has to be tailor-made for these patients. Evidence is there to use anti-VEGF monotherapy for proliferative diabetic retinopathy over pan-retinal photocoagulation, but in India, due to even financial constraint, it is still not our main practice pattern. There was a major debate after the protocol S criteria, which they studied a good amount of population, which told us what are the benefits of either of the treatment. But what we practice right now is still pan-retinal photocoagulation over, anti-VEGF therapy. Though the pan-retinal photocoagulation has only one downside, that the anti-VEGF monotherapy for proliferative diabetic retinopathy, which is non-tractional, showed superior visual acuity outcomes. So these are a couple of case examples taken from the study. And we have to keep it in mind that also when we are looking at the visual acuity, we are also looking at the diabetic retinopathy worsening. Okay, so this is what we follow these patients quite closely, and current evidence says that we can even strike a balance with this kind of treatment protocols over a period of time. Diabetic retinopathy severity scale is quite significantly achieved in these patients who have been grouped together on either form of therapy. And there are a lot of baseline predictive factors which can, tell you to which patient to choose, which not to choose for this particular therapy. So moving on to the most common form of occurrence, which is a diabetic macular edema, and how we do management of this particular entity in today's scenario. So we definitely emphasize on the systemic control of these major parameters, which includes blood sugar control, blood pressure control, and lipid control. But also we simultaneously tend to start the treatment nowadays on the ocular front as well. The mainstay of treatment remains for center involving diabetic macular edema, which is one of the main presenting feature as well for this kind of macular edema in most over that 90% of patients, remains the anti-vascular endothelial therapy. The only thing is that this injection sometimes have to be repeated every month, so it becomes a kind of a treatment burden for the patient. And most importantly, the patient has to follow up at least once in a month or once in 2 months. Focal laser treatment still has its own roles, and in select cases, we also use intraocular steroids as well. There are early visual acuity gains with anti-VEGF monotherapy. I don't have to emphasize the importance of this. But the most important point here to note is the number of injections over a period of time, they come down, and all these multicentral global trials has told us the sooner we start treatment for these patients, the greater are the benefits. And they also improves the functional areas beyond those related to the visual alone. So we have a lot of improvement in color vision, their peripheral vision, their mental health, their dependency, and so on. Anti-VEGF monotherapy provides good visual acuity outcome even in patients with poor baseline visual acuity. That means even if you have a poor visual acuity at presentation, still you can give them good amount of visual acuity gain, both functional and anatomical outcome. When should we, this is the $1 million question, where you want to initiate the anti-VEGF therapy? The current understanding tells us the sooner we start it, the better it is. Early initiation of treatment led to approximate more amount of visual acuity gains as compared to the delayed treatment intervention. And better visual acuity gains in treatment naive patients also receiving more than 4 injections have been seen over a period of 12 months. So that means the effect of this treatment lasts over a year, over second year, over third year of follow-up. And that is one of the main major booster for us when we start treatment. And we also are looking at fewer anti-VEGF injections were required over a period of time when we keep these patients on a regular follow-up. So do we need only ophthalmic treatment? No, we don't need only ophthalmic treatment. We need to treat patient as a whole. We need their social support, control of other systemic factors, mainly hypertension and lipid lowering drugs, and also in select cases, anemia, nephropathy, and so on. Lifestyle changes, which is a talk of the town now. Everyone is talking, especially after this COVID pandemic era, lifestyle changes, exercise, eating healthy, and also medical examination and support. So these are the key factors which has to be there. A lot of exciting treatments are on the pipeline, on the horizon. We are looking at something called as a port delivery system. That means we don't want to inject these drugs on a regular basis. So it will be once in 6 months or something like that. We're also looking at a couple of new exciting molecules which will tell us the way we manage these patients over a period of time, including faricimab and pralicizumab, whether we are going to treat this patient once in a month or once in 3 months or once in 6 months. So these are going to change, the treatment protocols are going to change. However, the main thing is collaboration between all the healthcare givers, especially the ophthalmologists and the diabetologists and the physicians. It is always better for the good patient care. And we always should work together to protect vision for every diabetic patient by timely referral and management. Couple of pointers which have been breakthrough as per Dr. Kim's talk is, one is the imaging of the retina is the only structure where we can take non-invasive modalities of pictures, and also you can predict many disorders. A glucometer-like test, the patient sitting at home is going to become a reality. Taking a retinal scan and sending to the the referral physicians or the treating physicians for the opinion, and the point-of-care care device will become a reality soon. And they're going to change the dynamic, the way we see these patients or we screen these patients. Over a period of time, a lot of emerging trends have been understood for the epidemiology of this disease, especially in Southeast Asian population and especially South Indian population, where we see the diabetic burden is more and even the retinopathy burden is more. We are learning for each passing year, and learning from our peers and also our colleagues. There is a good amount of consensus by our Indian colleagues as well as how to well manage diabetic macular edema, which is published and been practiced. And the treatment what we offer, as what we have seen, but the global trends from retina specialists from across the world, especially from the US, our trends are the same as what we are looking at the US counterparts as well. So the same treatment protocols have been followed in India. And we are very fortunate to offer the same kind of care to our patients. So successful treatment for any diabetic retinopathy patient, whether it is macular edema or proliferative disease, is not only about injection, not only about switching drugs to one to other, not about on the algorithms. It's also about personalized approach to each and every individual patient. So diabetes, as Dr. Vijay said, is a disease which can only be controlled but cannot be cured. Like blindness due to diabetes is preventable, and we should work towards that. We are already doing that, but we need to do more. Initial diagnosis and appropriate referral, even by an ophthalmologist to the particular physician or a diabetologist, is almost critically very important. As whenever we see retinopathy, we should mention that to the case sheet to the patient and give a letter of referral to the diabetologist as well, because we don't want only to treat retina, we also want to treat the patient systemically. So just to conclude my talk, we have new modalities of treatment, especially with the anti-VEGF, which is one of the mainstay of treatment, that is anti-vascular endothelial growth factor. In some select cases, we combine with steroid or laser. This is the first line of treatment as far as the treatment for diabetic macular edema goes, and also in select cases of diabetic retinopathy. Conventional panretinal photocoagulation still has a big role whenever we see a patient with proliferative diabetic retinopathy. We need to keep in mind we are in an economically challenged country, and economics play a big role for the patients to choose between the either form of treatment. Optical coherence tomography, especially the OCTA, that is optical coherence tomography. Angiography is one of the main important tools in monitoring the progress of the disease, especially whenever you have a patient with diabetes. However, thorough clinical examination and understanding patient needs is also crucial in decision making, with a good emphasis on systemic control, and it also has to be emphasized. Thank you very much for a patient hearing.
Thank you, Manoj, for really an incredible stuff, I would say, covering all the complications of diabetic retinopathy, diabetic eye disease, and how to manage them. I think it's very important to have a multidisciplinary approach. Since Professor Shantaram is here and Vijay is here, I just want to know what is the importance of this, because we were talking about it in the AMA conference as well. What is the importance of this 24-hour glucose monitoring and also the HbA1c, that is the glycosylated hemoglobin, in the, as far as the diabetic retinopathy or any other complications of diabetes is concerned?
Shantaram sir can go, he's there.
Yes.
Yeah. See, one thing, the diabetic specific complications, retinopathy and nephropathy related to one, the glucose exposure, two, the glycemic variability. The HbA1c reflects the glycemic exposure of the patient over the last 2 to 3 months. Higher the A1C, the more the risk of complications. And the UKPD has clearly shown what 1% reduction in A1C does to retinopathy and nephropathy. It's reduced. And the glycemic variability, now with the CGMS measures the glycemic, we know time in range. That is very important. At least we want 70% of the time in 24 hours, the patient has to be in the range. If it is not that, then the glycemic is more, and it generates more oxidative stress, more endothelial dysfunction, the more risk of diabetes specific complications. Not only A1C is related to the glucose exposure, but also related to glycemic variability. Improving the glycemic variability improves the A1C. Studies have shown that also.
Mohan, if you can add one point about hypertension.
Yes.
It's highly neglected. So we do what is called ambulatory blood pressure monitoring, where there is a concept of non-dipper. At night, your normal blood pressure falls 10% below the day pressure.
Yeah.
Which is called dipper phenomenon. Non-dipper is when you don't go beyond the 10% fall. And if you're a non-dipper, then you get more of retinopathy and CKD. Therefore, though your blood pressure might show 140/80, 130/80 while you're on drugs, it's very important to measure the ambulatory blood pressure from the retina point of view. So I do it for almost everybody who's on antihypertensive drugs to see whether they're really controlled, because there's a trough effect. You give telmisartan in the morning, by evening the drug stops working. Night it doesn't work. And nobody checks the BP in the early morning and all that, So it's better you do this ambulatory blood pressure monitoring. And your point about ambulatory blood glucose is also good, as Professor Shantaram sir said, but I think ambulatory blood pressure monitoring is also very important.
I think it's a very important point.
This is what Dr. Vijay has emphasized, a very important point, that is, which we normally don't do it, I think, which we should pick up and do it, measuring ambulatory pressure monitoring. In diabetics, most of the diabetic specific complications initiated by glucose, but it is sustained and the progression is due to the comorbidities. Diabetes does not, it initiates, does not drive the complication. That's why when Vijay also has highlighted in his talks, beyond a certain point, controlling glucose is not going to slow down the progression of diabetes or reverse the diabetes complication. It's only up to a certain point for a stage of microalbuminuria.
Yes, sir. Yes, sir.
Yeah.
Yeah. You lost your voice.
No. He finished the point.
I finished.
Yes, sir. No, I just wanted to, because since there are ophthalmologists also in the panel, I just want to ask you, we see, especially the young patients are coming to us much earlier. We used to see patients a long time back with 50 plus, but nowadays 30, 40. Yesterday also Sriram was telling that all his vitrectomies are in the younger age group, all the cataracts are 60 plus. but vitrectomies are younger age group. So I want to ask Muna, Saravanan, and Sriram, and also Vijay and all the other panelists as well. What exactly is the problem? Are we facing form? And they say because now their diagnosis of diabetes is now they used to say 40 plus, but now they are telling 25 plus. So you have to start screening. Number one. Number two is we see many patients coming with advanced proliferative diabetic retinopathy, and they say our glucose levels are perfectly under control. All other parameters are normal. My HbA1c is only 6.5 consistently, but despite that, they develop the problem in the eye. Third thing is I want to ask you because we see one eye mild NPDR, the other eye advanced diabetic eye disease. So what exactly is happening? Whether we have to do some other investigations to find out what exactly is happening, whether we are missing something else for these patients. So I want the panelists, Muna, Saravanan, and Sriram Gopal to answer, and also Shantaram to chip in.
Yeah, thank you, sir, for this question. And Manoj, that was a very nice talk. But I think most of us would agree that maybe next year, when we talk about diabetic retinopathy, we are going to talk about evidence-based pre-pandemic, the instructions that were given during the pandemic to minimize the doctors getting COVID, and what happened post-pandemic. Because I think now post-pandemic, we are seeing a large number of patients with very severe proliferative diabetic retinopathy. Yes, who never went to see a doctor in the last 2 years. A lot of them have small OCT pictures with a 3mm scan, which shows that maybe they had a little macular edema for which they received 1 injection. But a lot of times, probably due to varying reasons, nobody did a fluorescent angiogram because you were worried of slit lamp examination. We never did a good 78D. We missed a lot of proliferative changes, and then the patients didn't come back and things got worse. I think that is something that most of us in our practice are seeing, lack of follow-up during the pandemic. So I think that maybe a year later, our talks are going to be a little different. Maybe emphasizing more on laser, which is likely to be a more finite endpoint, and less on monthly anti-VEGF injections. I think that is one point I would probably like to make. Regarding younger patients, yes, but if you ask them carefully how long has the diabetes been under control, then they'll say yes, in the last 3 months. So not more than that. And the third point is on your question of asymmetric retinopathy. If the patient is phakic in both eyes, has no glaucoma in one eye, and still has asymmetry, then I would want to do a Doppler or image the vessels to see whether there is some asymmetry. Also look at the blood counts. Look to see if patient has central vein occlusion in one eye, which is causing the asymmetric picture.
Very good. I think it's a good point. Saravanan?
Yes, sir. As regards to asymmetry, we have to look at whether it's a superimposed CRBO, ocular ischemia syndrome, post-cataract surgery. And apart from that, feature most commonly missed is you have advanced retinopathy, but it's not visible. It's what we call as featureless retina. Doing a fluorescent will throw up the diagnosis. So these are some of the things, and we have to look at local protectors like any kind of optic atrophy or extensive choroidal degeneration because of post-uveitis or post like high myopia and all those things. So that's about asymmetry. Apart from that, it's a very nice talk by Dr. Manoj, encompassing all the aspects, not only the treatment aspect, but also the socio-personal aspects of the management of diabetes. So I think a lot is to be done, and this will be sort of a nice eye-opener to how we should go in the future.
Thanks, Sarun, for nice inputs. Sriram, your thoughts on this?
Yes, sir. Very nice talk, Manoj. Thank you very much. As Muna ma'am said, totally agree with this whole thing which COVID has thrown up. I'd just like to add a couple of points to that. Madam was talking about how we try to stay a little further away from patients, so we've missed a lot of things. Another thing which has also been happening over the last year or so is they don't go to their diabetologist as well. So a lot of them have had very high blood sugars. They've not even gone to a lab to check it, fearing acquiring COVID. And the steroids given in COVID. A lot of patients actually come up with very, very bad blood sugars, and I would have seen them just before COVID, and they have a very bad worsening because they've developed COVID. They've literally been pumped with steroids, and sugar has not been taken care of. So that is one point I wanted to make. And with regards to the asymmetry, yes, invariably, if like the factors which Madam said, unilateral optic atrophy or pseudophakia is not there, they invariably have some sort of carotid artery disease. And the only problem with that is the normal carotid Doppler picks up only the extracranial carotid disease. A lot of patients I've seen having intracranial carotid artery disease in the absence with absolutely normal carotid Dopplers. So these patients are the difficult ones to pick up. And with regards to therapy, yes, I don't think we should be going down the path of monotherapy. But my question to Muna ma'am and Saravanan and Dhanashree madam as well is, why don't we take up combination therapy in a big way? Why should we stick to either intravitreal or laser alone? Why don't we make combination therapy as a standard protocol?
You're talking about PRP?
Yeah, PRP, yeah.
Okay.
Because the benefits
is,
of
like,
anti-VEGF has been clearly demonstrated by both Protocol S and by Clarity study. So anti-VEGF have a much superior this thing compared to PRP alone. But given all the pitfalls we have, especially in a country like India, monotherapy, we cannot take it up in a big way. So why not go for combination therapy as a standard of care?
Probably it'll depend upon the severity of the presenting disease at the point of presentation. But as regards to monotherapy, if you look at all the studies, they have not shown that the ischemia is getting better. Yeah. Just trying to put a lid on what is underneath. We don't know what is going underneath. The ischemia is always there. So once you stop the injection, it's going to flare up. So monotherapy itself is not a way to go. Probably it may add as an adjunct when you have a severe retinopathy where your plain PRP is not going to be enough in those patients. But monotherapy for PDR, I don't think it's a no-go.
Yeah, that's exactly my point as well. Monotherapy long-term doesn't work out, but monotherapy has its own benefits, like the central macular thickness at the end of treatment is much better than PRP.
That is when you have a diabetic
field is better. Okay. No, even in the eyes without macular edema. Both Protocol S and Clarity, even in eyes without macular edema, the patients did better. The only thing where monotherapy didn't really score is, in spite of monotherapy, they still had progression of visual field changes, which they were not able to explain. But monotherapy still had its own benefits, even in the patients without macular edema. So why not opt for combination therapy as a standard of care?
So in a real
I
world,
agree. These patients with fibrosis where you're fearing of progression into TRD is a different thing.
No, why not do focal laser for macular? I have my patients whom I have done focal laser 15-20 years back. At that time, Babu Rajanan used to tell me, no, do the temporal C. So I used to do the temporal C for the focal laser for the macular edema at that time. At that time, no anti-VEGFs were available. And these patients are still coming to me without any problem at all. And the hesitancy to do laser, especially when they, that's what I'm asking.
I think most of us in the panel would still do so. I'm speaking for others. I think most of us in the panel would still do focal laser.
Where the leaking lesions is a microaneurysm, the role of laser is very important. But when you move on to the diffuse macular edema, where the capillary bed sort of leakage is happening, there I think the response to therapy is not that very good. Even if you look at the DRCR net study where they looked at the MMS or macular grid MMG laser for retinopathy, they showed it was not working. So the minimal macular grid did not work well. So for diffuse macular edema, laser is not, I don't think it's a good way to go. But for aneurysmal leakage, I think that's a nice treatment.
Okay.
Regarding the Sriram Gopal's question,
yes.
Your question is very pertinent, whether we should have a combination therapy for PDR. So probably there is some subset of patients who will benefit with combination therapy, and you can definitely go ahead and try combination in that subset. But I wouldn't, advocate a combination therapy as a, therapy universal treatment for all patients of PDR, because that carries a very high risk of, progression of TRD, fibrosis, etc. Another scenario where you can probably think of combination therapy is a patient where PRP has been done extensively, but still the patient continues to have NVE which will bleed intermittently, not to the extent where surgery may be required, but just a mild bleeding might be occurring. Now, such a NVE can be probably kept under control by giving repeated injections of anti-VEGF, provided there is no fibrosis there. So
Nice
some
point.
subset of patients will benefit.
Yeah. I think it's a good discussion. We go on to the next talk. Before that, I just want to the role of these antioxidants. This curcumin has come now, and the saffron. What about all this in diabetic retinopathy? Can anybody tell, or after Dhanashree talk, probably we can take that. Ravi Shankar, introduce Dr. Dhanashree, the panel speaker.
We'll go to the final speaker of the day. Thank you so much, Dr. Dhanashree Ratra, for patiently waiting for your talk after the long talks and the discussions. And Dr. Dhanashree Ratra is the senior vitreoretinal consultant from the Temple of Eye in this part of the world, Shankar Netralaya. The proud moment for having her here. She's presented a lot of papers nationally and internationally. She's authored a couple of books and as well as written many articles on retina and diabetic retinopathy, and a leading consultant in this part of the world. Thank you so much, Dr. Dhanashree Ratra. TNOA appreciates your presence today and your talk, awaiting for your talk. Thank you. Over to you, please.
Dhanashree is a very good surgeon as well. We've seen her so many times operating live surgery, and really fantastic. Dhanashree, thanks a lot for coming.
Thank you so much for the kind introduction and also for the kind invitation. So my topic today is unmet medical needs in diabetic macular edema. I hope my slides are visible.
Yes, sir, Dhanashree.
No doubt there has been a great advance in the management of diabetic retinopathy and diabetic macular edema in the last decade and a half. But I think there are still some unmet needs which we need to explore. No financial interest. So the last 2 years, the entire world has been reeling under the effects of this corona pandemic. But a pandemic much deadlier than the corona pandemic is happening right now, and that is the pandemic of diabetes mellitus. And you would be surprised that not cancer, not HIV, not tuberculosis, but diabetes is the leading cause of death globally. And India has a dubious distinction of having the second highest number of diabetics in the world. And you saw these numbers in Dr. Kim's talk also. And it might not, mean much to you, so many millions of patients, but to put it simply, I will tell you that this means that 1 in every 6 diabetics in the world is an Indian. Now you can calculate the number of diabetes in India. It's a staggering number that, I cannot even imagine. So the prevalence of diabetes is high in India, over about 9 to 12%. And in India, Tamil Nadu has a high prevalence of diabetes and diabetic retinopathy, over 10.5%. So diabetic retinopathy prevalence, as you saw, ranges from about 18 to 20%. And diabetic macular edema ranges from about 5 to 15%. So having looked at the disease burden, we must explore the unmet needs in our this burden. So the first and foremost unmet need, I feel, is to improve the compliance of patients. So we know that a lot of diabetic patients are lost to follow-up. Nearly over 50% of patients, they discontinue the treatment. And as a result, there is underdosing and suboptimal visual improvement. The most often the reason for this non-continuation of treatment is non-affordability. Over 40% patients are not able to afford the continued treatment. And of a few patients, they give up treatment because of non-improvement of vision. And some of the patients, they also give up treatment because of apathy and fatigability, which can occur with prolonged duration of treatment. Unfortunately, the high financial cost, repeated visits to the doctor, travel to other parts of the country, recurring expenditure for the test, and a need for a person to accompany every time the patient goes for a checkup, old age, comorbidities, and treatment anxiety. These are all the points which contribute towards non-compliance. So what we can do to prevent non-compliance is the one solution is to reduce the financial burden by reducing the cost of the treatment, by reducing the number of visits and the number of injections, and can have also long-lasting durable treatment. So the insurance companies or the government can help in financing of the needy patients. The hospitals or the institutions treating diabetic retinopathy can have some co-packaging of the tests where they can be charged collectively for the tests and not singly, so to reduce the amount of expenditure on the tests. maybe a diabetes care package can be developed where OCT, FFA, blood tests, etc. can be clubbed together. Very recently, the FDA has approved this ranibizumab port delivery system, which is supposed to give a longer duration treatment lasting nearly about 6 months. Possibly this might help towards reducing the number of visits and reducing the burden on the patient. What else we can do to improve the adherence of the treatment? Some incentives can be given to the patient to continue the treatment, and some pharma companies are already giving 3+1 package where every 3 injections, 1 injection is free, or for every 2 injections, 3 injections are free. So these incentives might help in inducing the patient to continue treatment. Then reminders can be set for the patient to report for checkup and treatment. So clinics can proactively call such patients and ask them to come for their scheduled appointments and the treatment. Some IT or information technology can develop some apps which can monitor timely treatment, and these apps can also be linked with the measurement of HbA1c, BP, etc. 2 companies are also looking at home monitoring with OCT, and these devices can be used by the patient at home. The OCT can be taken and this can be transferred medicinally to the ophthalmologist, who can then advise the patient to come into the clinic for injection or no. And this possibly might help in future in reducing the burden. The second unmet need is to increase the awareness. And this is the theme for Tnoa now for the next 1 month, to increase awareness, accessibility, etc. And this is definitely needed because there are a large number of patients are completely unaware of the need for regular retinal evaluation. And thus they are at an increased risk of severe vision loss. So patient education at every stage of the disease through information booklets or pamphlets, newspaper articles, advertisement campaigns or social media must be done. Patients must be taught to self-monitor their vision. The caregivers also must be educated about the possibilities of vision problems. The employing agencies or the employers or the companies can make the health checkups or vision checkups or retinal screening mandatory for diabetic patients. So this way at least they can go for periodic checkups. And the patient must be made to accept the fact that the treatment is long and a lifelong surveillance is necessary. I mean, however long duration of the agent that we find, the diabetes is going to outlive that agent. And as a result, you are going to have a long-term treatment for every diabetic retinopathy patient. So the patient, if the patient accepts this, then it will be better. They will have better compliance and adherence to the treatment. The most important unmet need right now is to bridge the professional knowledge gap. And this has been, of course, talked in the previous talks also. More often we see that the physicians or the diabetologists, that they fail to give proper importance to the regular retinal evaluation. And there are many misconceptions that I have seen among the physicians or other non-retina consultants, that if the HbA1c is controlled, the retina will not be affected, or if the vision is normal, that means the retina is normal. Not always, not necessarily. So one must, have this knowledge. In the last, decade and a half, there has been paradigm shift in the way the diabetic retinopathy is classified and managed and treated. Now, the curricula at undergraduate and postgraduate levels must be modified to include this basic knowledge as well as the latest information about diabetic retinopathy. And regular refresher courses, CMEs or training courses must be organized for not only for the retina specialists, but also for physicians and for non-retina ophthalmologists, so that they can update their ophthalmic knowledge and skills, including information on new diagnostic tools, medications, or technologies. Another unmet need is to improve the accessibility. Widespread screening of diabetic retinopathy is essential, where the screening can reach the doorstep of the patient. So community-based screening or a primary health center-based screening is a must. The community health workers can be trained in screening for diabetic retinopathy, which Dr. Kim very nicely elaborated, that it need not be a retina specialist who screens. It can be anybody, an ophthalmologist, optometrist, physician, social health worker, anybody can be trained to screen for diabetic retinopathy. Teleophthalmology can help you reach remote areas where doctors may not be possible. One retina specialist can be designated as a screening person who can be attached to many diabetes specialists in the neighborhood, so that the patients can be mandatorily be referred to this one person who can screen and keep track of their diabetic retinopathy. More and more junior doctors should be trained in laser and anti-VEGF injections, so that in short, we create a diabetes task force who can take the diabetic retinopathy screening and treatment to the masses and to the doorstep. So screening is now easier with a lot of tools which are available, such as portable cameras, handheld cameras, and non-mydriatic cameras. And screening can be done as an opportunity screening or a mass screening, but essential to screen all diabetic patients for diabetic retinopathy. And the foremost unmet need, I feel, is to develop India-centric research. So it is vastly, our diabetic population is vastly different from the population that you see in the West. Their dietary habits is different. The social and economic conditions are different. As a result, the diabetic retinopathy trends that we see in our patients and the diabetic retinopathy picture that we see is also totally different. We must not, verbatim take the results from the trials which are conducted mainly in the West, but we must, look at our population, look at the trends to identify the emerging needs for our population. We must analyze the real world evidence and determine the effectivity of new interventions. And most important is to have collaborate and plan multi-center studies all over India, and where we can, form our own treatment guidelines specific to our population. So we have a vast population with diabetes, and we have equally large number of retina specialists in the country, and we can have our own DRCR network, where we can conduct not only epidemiological studies which are already being done, but also clinical studies where we can have treatment guidelines for our particular population. And I think that one important lesson which this corona pandemic has taught us is that health is of paramount importance and human life is very precious, and we must do all possible to preserve that. And so the time to innovate is now, and I thank you all for your patient listening. Thank you.
I think it's really a fantastic overview, Dr. Dhanashree, for your nice inputs on diabetic macular edema and also the unmet needs, I would say. And I just wanted to, before we go to the panel, I wanted to ask you, one of the main reasons for the non-compliance is the patients are finding it difficult to come to your center for every 4 weeks for the injection. Apart from the cost is also very prohibitively high. Nobody can afford even about 5,000, 6,000 rupees a month, even for an Avastin, I'm telling you about. Leave alone the thing. One is the compliance, is the, the accessibility, because they're not able to come, and also because of the cost as well. So is there any way we can overcome this problem? For example, I'm just giving a suggestion, whether it's possible to give this anti-VEGFs. Of course, we have to ask the companies to give this thing to reduce the cost. Whether to give the anti-VEGFs, we can give it in the outpatient in the area where they are. Like what they are doing in the US, in the office. They're not taking the patients to the theater to give the anti-VEGFs. So even in UK, some centers are doing that as well. So I want the opinion of Dr. Muna, Saravanan, Sriram, and also some inputs from the other panelists as well on this.
So the risk of infection is very, very high in our country, sir. If you look at even the...
Saravanan, your voice is not clear. Unmute yourself.
The basic concept, risk of infection is...
No, we're not able to hear you. Yeah. Little louder.
The problem is that the risk of infection in the hospital, in OP-based injections in India is very, very high, unlike in the US. And if you look at the basic research where they do the multiple cultures and all, the risk of inadvertent infections and contamination is very, very low in US.
Voice is not good, Saravanan. Are the other people here to hear?
I'm able to hear him to a certain extent, sir. I think what Saravanan is trying to say is,
yes,
in India, in the Indian scenario, the risk of infection is very high. Your ambient cultures grow a lot of organisms, and it is not a very safe practice to inject in the OPD. Even abroad, sir, they don't really inject in the OPD. They have a specific designated clean room where they do the procedure. But our OPDs, we generally don't have such a room. If you can, you need not really take them into a laminar flow theater to do the procedure. If you can designate, let us say, a small room inside your OT, in your ante room of your OT complex or something, to have it as a clean room, you can still do it there. But you need one specific designated clean room to do the procedure.
Yeah, that clean room is not a very difficult thing to have it in a perfect.
You shouldn't be doing anything else in that room.
I'm telling. I just want an opinion from the other panelists also, how to take it forward, how to improve the compliance. Apart from the cost,
I'll just say one point here, sir. See, I'm an individual retinal surgeon, and what I try to do to improve compliance of these intravitreal injections is, whenever I call them for the review at 4 weeks, I ensure that they spend, say, a maximum of 4 to 6 hours in my hospital. They get everything done and go back. In the sense, when they come, they first get the scan done, see me. They probably go for lunch. I have a separate session of theater running between, say, let's say 3:30 to 5 at the end of the day, where all my intravits take place in a separate session. I don't do them in the morning theater session. So whatever I see that day, I inject them that evening and send them back. Because it is not only the patient who comes and goes, we have to understand he brings along with him a working member. It is one day, for most people, it is 1 day loss of pay. So for him to come one day, spend the whole day, have it checked, advise injection, then go back and again bring him for another day for an injection. So try to make it just 1 day visit.
Yeah,
so I have a separate intravit session at the end of the day. I do it in my own theater itself, but I have a separate session for that.
That's what
I don't do it.
Yeah, that's what we are also doing. But Muna, what's your take on this?
Yes, sir, definitely. I would agree with Sarvanan and Sriram about not having injections in the OP. We have a separate anteroom now in our theater complex where we can give the injections. And we do on occasion, if the patient is outstation, wants to go back, we do give the injection the same day. And we do a next day teleconsultation to make sure everything is fine. But I think what we are lacking most is, even in big medical colleges, big government hospitals, not everybody, including a postgraduate, has access to seeing the fundus with an indirect ophthalmoscope. And I think that is why patients have to come all the way to the city or to see a private practitioner. I think we need to equip our medical colleges, especially our training institutes, better a simple indirect ophthalmoscope, and training your postgraduates to examine the retina. I think that will go a long way in reducing. Then the patient will not have to come here, because not every medical college is overburdened with cataract surgeries. Not every cataract theater is overflowing. So if someone is able to diagnose and treat in the same operation theater complex where cataract is done, I think that takes care of a lot of problems.
The scene is changing, Muna. I would say medical colleges about 5-10 years back, they didn't have equipment, but now I think the MCI is very, very strict about all these things. Now all the most of the medical colleges, because
yes,
I go as examiner for.
Can I make a point, sir?
Yes, Sriram. Yeah.
Sir, I partly agree with what you're saying. The medical colleges are better equipped. But if you recollect, even in that webinar on Friday, they were talking about how a lot of equipment is being there in medical colleges, but it is not being put to use. Second, I don't want to bring up names. Somebody said that they're having around 200 diabetics in their OPD and they're not able to see fundus. In a district hospital attached to a medical college, then will be at least having a dozen postgraduates. Even if you depute 2 of them to see fundus for all the diabetics walking into the diabetic clinic, they're not going to do a detailed 360-degree fundus examination. They just need to ensure there is retinopathy, no retinopathy, that's all. For that, they can depute 2 postgraduates to do it, and it helps a postgraduate as well. If he does around 30-40 indirects a day, he need not do a detailed indirect. All he needs, if you can pass off with a 50-degree posterior pole photograph saying there's no retinopathy, one look at indirect can give you an equally good
even 90 diopter slit lamp will suffice. I think it's a point.
I think that is the point Madam is trying to make, that people don't take up the indirect and use it.
Yes, I think it's not.
We rely more on the 50-degree fundus photograph rather than one look at the indirect.
Absolutely. And Professor Shantaram, what's your view on this? So we have on one side we have got patients who are coming, but on the other side we have patients who are not compliant with the treatment. not only from the eye point of view, but also you from the general point of view also, I'm sure you'll be facing the same thing because of the cost involved, because of the accessibility, and so many other factors are coming in way. And Shantaram and Vijay, sir, I want your opinion.
So one is that you are talking about accessibility and affordability.
Affordability, yes, sir.
Accessibility and affordability. Accessibility, see, most of the centers, good centers can have satellite clinics in various places, and they can be connected to the main center where tele-ophthalmic is integrated to get the opinion treated. Second thing is, as Madam has pointed out, train a lot of PGs, depute PGs to the diabetic clinics and various other clinics where you can pick up the retina cases, screen them and do it. And affordability, probably see the centers like you, Shankar Nethralaya, Aravind can tie up with corporates. Corporate is part of the corporate social responsibility, can get these drugs at a cheaper price. I mean, not at a cheaper price, they can sponsor the drugs as a part of corporate social responsibility.
No, actually, the Novartis people are doing that as well. They're giving, for example, every 3 Lucentis, they give 1 Lucentis free of cost. So any Novartis guys, because this program is being sponsored by Novartis. And before this thing, as a president of a TNOA, I wanted, because we discussed, Sriram, we discussed this in the IMA conference as well. I want a consolidated document from people like Sriram, Dhanashree, Muna, Saravanan, and all the retina consultants, saying that this anti-VEGF is the mainstay of treatment, because not the laser, because everybody was thinking laser. Now it's anti-VEGF is the mainstay of treatment as far as the diabetic retinopathy is concerned. And it is important that the insurance companies cover this anti-VEGF cost. So as a president of the TNOA, what I thought was I'll represent to the insurance companies and cover the cost of this anti-VEGF. But I need a solid, evidence for that. No, saying that this anti-VEGF is the mainstay of treatment. So if Sriram, you can coordinate and get the document ready and send it to me.
Yes, sir. Yes, sir. Actually, this thing came up in another Delhi Retina Forum meeting as a group as well. There is a document by the Ministry of Health and Family Welfare called Standard Treatment Guidelines in Ophthalmology. And I'm sure it's been, Saravanan can tell me, Dr. Prajna sir actually had compiled the whole thing. I don't remember which year this was. It must have been quite some time back, because the treatment of diabetic retinopathy doesn't even include anti-VEGF.
Yeah.
Leave alone mainstay, doesn't even include anti-VEGF. I think it was 2015 or 16. Kim sir might be knowing which year it was. It's been quite some time, sir.
I don't remember that time, but you know, anti-VEGF is in one of the essential drugs in WHO's list. So, in fact, it is a vast
I have that with me, sir.
Sorry, if you have a consolidated document, sir, from all of you, because you're all the stalwarts here, and if you can get that, then we can approach the insurance companies and tell them that you have to, because just like they are sponsoring or insuring the giving money for cataract surgery or vitrectomy or glaucoma, they have to give for anti-VEGF as well, because many insurance companies, 90% of the insurance companies are now refusing reimbursement for anti-VEGFs. So only about 5-10% are giving that. So you know what these guys are here in this panel, in this Zoom? Ravi Shankar? Are the Novartis guys here?
Sir, Novartis representatives are not there, I think. But just to give 2 additional points on the comments what you have made. 3 years back, we had 2 meetings representing Novartis on this health forum from on the Indian platform, global, national platform, considering anti-VEGF or intravitreal pharmacotherapy as one of the mainstay of treatment. So which was not fruitful, but from last year, 1 year onwards, Vitreoretina Society of India is quite active on this. We have done quite a good amount of work. We have even done 2 surveys on looking at the practice pattern surveys in India. And we are able to, penetrate little bit of insurance market. not entirely, but little bit of insurance market. The work is already going on. The documents I'll get you from VRSI. We can replicate the same state to state because the health is a state subject. The moment we approach any insurance company, they say health is a state subject. We cannot just give a national guideline. So we can replicate the same thing on the TNF from Tamil Nadu. No problem.
Yeah.
I'll get you the
Manoj, actually, this document which I'm talking about is from the Ministry of Health and Family Welfare, Central Government of India.
Yeah, but whenever you go for any insurance related policy, health.
No, I agree. I get your point. But what I'm trying to say is this document, if you let me share my screen, I can even show it. I have it on my iPad. It doesn't even include anti-VEGF. The protocols are that much outdated. The government guidelines, the so-called guidelines, if you can call it.
That is not updated, but we can update it.
It's not been updated for quite some time.
I want to ask Professor Shantaram and Vijay, sir, what are the what do you call suppose you have a diabetic foot, Vijay, or any other problem for that matter, is it reimbursed by the insurance, sir? It's covered by the insurance?
Regarding diabetic foot, only the hospitalization is covered, Dr. Mohan, not outpatient treatment. The inpatient is covered completely. For any surgery, vascular surgery, angioplasty, anything is covered, provided it's hospitalization. Diabetics get any sort of reimbursement only if they are hospitalized. The diabetics do not get any reimbursement in their outpatient, to the best of my knowledge.
Suppose they are getting operated for having a foot surgery.
Yeah, it's completely covered.
Completely?
Yeah, it's completely covered.
Completely covered. What about dialysis for diabetic nephropathy patients?
Dialysis also is covered, provided they get hospitalized, not for outpatient dialysis. No.
If they can do that, why can't they do anti-VEGFs? This is a very important thing, you know. If they can do all other things, anti-VEGF is also a very important armamentarium, I would say.
Sir, the challenge is the variability and also the pricing, sir. There is no uniform pricing on that. So that is a big challenge. We cannot put a price cap.
No. What I'm trying to say is they can give a basic, for example, they can give probably the Avastin cost, which is about 10,000 or 8,000, whatever it is.
No, sir, it is not about the cost of Avastin or cost of Lucentis, sir. It actually depends on the insurance policy. I've seen patients who have insurance policy where there is clearly one rider saying that intravitreal injections not covered. He's taken a policy after signing under that particular statement. So if the patient holds such a policy, you cannot go and ask the insurance company, why aren't you not covering? The patient has accepted that. The problem is nobody reads all those fine points. That's a different thing.
The patient has accepted, Sriram. What I'm trying to, why the insurance company should put that rider? That is what I'm asking.
He wants to make his money, sir. He knows this is how his money
are agreeing to. They are agreeing to.
No, when they can give for all other complications, dialysis they are giving, foot surgery they are giving, cardiac bypass they are giving, liver transplant they are giving.
Sir, it is like this.
Why can't they give it for the eye? That's what I'm. Let's fight it out. I think as part of the TNOA, we should.
Sir, the CM scheme pays, the government pays for it, but the other insurances don't pay for it. The only issue is that, for the insurance companies, the problem is the number of recurring injections. That is one of the issues they have, or they can't limit it for any surgeries or procedures. It's limited, whereas for insurance, for the injections, there is no limit. How many injections you have to go?
Yeah.
Sir, and more importantly, if you look at the number of people who will require a coronary bypass versus the number of diabetics who will require an intravitreal injection, I'm sure there should be 100 times more. So he is going to lose money. That is why he doesn't want to cover. And even in the government CM scheme, sir, again, a point of our getting outdated only. Still, the CM scheme, a government-sponsored scheme in a taxpayer's money, carries only a brand name. It only carries Lucentis, which is not available in India. It doesn't even have Accentrix. You cannot do Accentrix, and leave alone any Indian biosimilar. You cannot even do Accentrix under the CM scheme.
No, now you can do biosimilar, Gopal.
We are able to do biosimilars.
Yeah.
Okay,
Only
ma'am.
thing is the total amount they get per year is for I think it's something to do for the entire family. So I think if they have to spend it all on injections, there'll be nothing left for other diseases. I think that is
and
the
for
main
DME,
problem.
they've limited to 6 injections, ma'am, in a year.
Mm-hmm. So, one final thing, instead of going for anti-VEGFs, suppose we give steroids, which is going to stay there for a longer time. I'm talking about Ozurdex. I don't have any financial interest. So instead of having every 4 weeks, so what's the take on that?
Sir, I think Ozurdex has its place. And in a non-compliant patient, I would think even Ozurdex has its risks because of risk of intraocular pressure rise. But probably there are certain conditions where we would opt for Ozurdex, but not always. I think ocular safety, probably anti-VEGF is better than Ozurdex.
Yes, sir. I totally agree with Madam, sir. 3 main points. One is pseudophakia. Another one is very gross macular edema, a lot of times in the presence of nephropathy. And third one is, even though the anti-VEGF works, if he needs very frequent injections. So that time Ozurdex might be a better option. As like Madam said, non-compliance I don't think is indication for Ozurdex, because if at all anything, I'll follow him up more closely for intraocular pressure rather than anti-VEGF patient, which if I inject and he's fine the next day, I forget about him for a month.
So Ozurdex is not advisable as a first line.
It is got its role.
Certain cases, not
Certain
not
cases,
as a,
no, not as a routine.
It is not a
no,
replacement.
no,
It is not a substitute.
I think we have come to the end of this wonderful webinar. I request my co-moderator, is anybody else want to give any other inputs on this? Then we'll go to the closing remarks.
Thank you, sir. It is indeed a pleasure to propose the vote of thanks and give the closing remarks of today's webinar. And I personally feel, and I do agree, that everyone in the panel, the faculty would agree with me that there was a lot of take-home messages and a lot of cross-learning at the end of the day. I really appreciate the points from Professor Dr. Shantaram and Professor Dr. Vijay Viswanathan for telling us the overview of diabetology and the diabetic perspective as such. And thank you so much, all the panelists, Professor Dr. Shantaram, Dr. Mona Bende, Dr. Sriram Gopal, Dr. Saranan, for being the panelists and discussing all the points very clearly and logically. I would thank the speakers of the day, Dr. Vijay Viswanathan giving the keynote address, Dr. Kim Ramaswamy from the Aravind Eye Care System, Dr. Manoj Khatri, Dr. Dhanshri Ratra Shankanetralia for speaking to us on the modality of treatment, telescreening, and all the recent management and approaches. Thanks a lot. Thank you, Novartis, for medical support and giving us the continuous medical education support for various programs. Thank Numerotech Technologies for giving the back-end support. The Tamil Nadu Ophthalmic Association is indeed privileged and happy to have had you all on board today, and on this wonderful day where it's not only World Diabetic Day, it's the birthday of Nehruji, and lots of much other things where you have created a lot of awareness. Let all this which have been discussed today spread among the general ophthalmologists, general physicians. And one last request to Professor Dr. Shantaram and Dr. Vijay Viswanathan on behalf of Tamil Nadu Ophthalmic Association. We requested, we did this in the IMA recently, kindly sensitize the physicians. I think you at your level can definitely do it, to refer patients at a very early stage. It's not that they are not referring. In institutions, it happens. In private clinics, probably because of the busy schedule, because of the waiting time, which is very long, they can't go into other rooms, or certain other reasons. Some physicians have personally told me that they lose the patients if they are referred. Lots of scenarios behind, but at the end of the day, it is the patient's vision, patient's health, which is our primary care, and kindly do this for us. And Tnoa thanks you all once again. Have a wonderful day ahead.
Thank you very much. And on behalf of the Tnoa, I'd like to thank all the speakers, panelists for this wonderful webinar. Stay tuned for more activities from TNOA. Next Sunday, we are having the Great Oculoplasty Debate, which is a TNOA along with Shankanetra alumni. We are doing this between 11 and 1 same time. Looking forward. Stay tuned. Enjoy your day. Enjoy your year. Thank you. Bye.
Thank you. Thank you, everyone.
Thank you, sir. Thank you, sir. Thank you.